Good evening. This is Dr. Vittal, and I welcome you for the educational program conducted by the Vijaya Diagnostic Centers. I'm the senior consultant in the Department of Microbiology, Vijaya Diagnostic Center. Today, our main topic is blood cultures and their clinical importance. Blood culture. What is blood culture? The pathogenic organisms, when they invade the bloodstream, it is called septicemia. And for the diagnosis of the organism which is invading, the test we perform is the blood culture. This blood culture is most important in the critically ill patients and the finding of the pathogen which is causing the invasion by infection will be treated properly, and the mortality and the morbidity will be reduced by diagnosis of or performance of this particular test properly. Though we talk more about blood cultures, actually, what is the procedure of the blood culture? How do we perform it? And what are all the precautions to be taken during the performance of this test? And how do we report? All these are clarified to us by Dr. Vishala Sarma, who is the head of the Department of Microbiology, Vijaya Diagnostic Center. She has done her MBBS from Gandhi Medical College, and her post graduation in microbiology is also from Gandhi Medical College. She is an NABL assessor, as well as she has a vast experience of 14 years as a clinical microbiologist. Now, let us listen to what Dr. Vishala says and explains to us about the blood cultures and its importance. Over to Dr. Vishala.
Thank you, sir. Uh, First of all, I welcome all the consultants who are there and other executives who are there for this interesting topic. The topic is on clinical significance of blood cultures. So before I go into the topic, I would like to these are the points covered in this discussion: introduction, collection, what are the various pathogens causing bloodstream infections, significance, and the conclusion. So coming to the introduction, before directly going into the topic, I'd like to say that in emergency, number of patients attending the emergencies, around 14% of the cases are usually because of infections. And among these 14% of infection cases, those who get admitted, more than 70% of the patients are mostly because of viral infections. But around 30% of the infections are mostly because of bacterial and other causes. And among the bacterial, only around 15 to 20% of the bacterial infections can be isolated through culture in a laboratory. So there are some uncultivable bacterial pathogens which are usually not detected by routine culture, for which we may need additional settings like molecular methods. And so whenever we say a culture, it is usually the most commonly identified, easily cultivable bacterial pathogens. So coming to the collection of blood culture samples. So when do we suspect a case that a blood culture sample has to be collected? So there are different stages. One is bacteremia, the other one is septicemia. In bacteremia, we mean to say that there are bacteria circulating in the blood. And when we say septicemia, it means that these circulating bacteria have caused certain immune response, which is defined as sepsis inflammatory response, severe inflammatory response syndrome. So whenever a blood culture sample is collected, proper antisepsis is the most important aspect. In two levels, that is, one level either with alcohol and 1 to 2% betadine, or or it could be with 70% isopropanol and chlorhexidine combination. So during process of collection, retouching of the site again with or without gloves is not entertained, and it should be the first sample to be collected in the order of draw, and should be and the sample should be collected before the initiation of the antibiotics. And aseptic transfer of the blood into the blood culture bottle is also very important. So what is the need for this blood culture bottle in when it comes to collection of samples for septicemia or bacteremia? So in the large volume of blood which we see, the bacteria circulating in a smaller proportion of blood which we draw is very less. So in order to enhance the growth of these bacteria, the blood is initially put into a blood culture bottle, so that the bacteria will have enough medium to multiply at a faster rate, so that the blood organisms can be identified in the lab much better. And at the same time, it also has certain substances which can nullify the other antibiotic substances which are naturally produced in the body or which the patient has taken, so that the bacteria can grow much better. And the blood to broth ratio is also equally important. It is usually 1:10. So we have commercially available blood culture bottles which are validated for use for neonates and children separately and for adults separately. So whenever we are collecting a blood culture sample for neonate, it should be around 0.5 to 1 ml. In children, 1 to 15 ml, and 7 to 10 ml in adults. So where this approximate volume is equally important, because it increases the yield of the bacterial pathogen from these blood culture bottles. So coming to the number of blood culture bottles that have to be collected. So two blood culture bottles, which is known as a blood culture set, is recommended for any bacteremia or septicemia. So one is an aerobic blood culture bottle and the other one is an anaerobic blood culture bottle. So why are the two blood culture bottles required? First of all, the volume of blood added is additionally, as we are collecting in two different bottles. And secondly, the anaerobic medium enhances the growth of certain gram-negative bacteria, and thus the isolation of the pathogen in a case of bacteremia or septicemia is much better when we take two blood culture bottles, which is equivalent to one blood culture set. And this, when it comes to when we are suspecting catheter related bloodstream infections, or especially in ICU settings, two blood culture bottles, one from central line and one from peripheral line is preferred. But again, two blood culture sets is the best among this. Then coming to diagnosis of endocarditis through culture, we should take two blood culture sets. That is, one set is equal to one aerobic and one anaerobic bottle. So two blood culture sets more than 12 hours apart within one day is preferred, or three blood culture sets at least with one each set. There should be more than 1 hour gap, and there should not be more than 12 hours gap between the next set in 24 hours time. So, what are the usual clinical conditions where the blood culture is ordered by the clinician, which is fever less than 36 or more than 38 degrees Celsius with heart rate more than 90 per minute and respiratory rate more than 22 per minute. Usually, in such cases, WBC count is either less than 4,000 or more than 12,000, or it could be more also with more than 10% band forms. They may have additional findings like low platelet count, creatinine levels. The other risk factors associated for bacteremia or septicemia is usually the age, their other comorbid conditions, altered mental state, or there is identified focus of sepsis. So, what is the difference between the blood culture, which is ordered as automated and ordered as conventional? So, in an automated blood culture, the blood culture bottle is directly after collection of the sample. The blood culture bottle is immediately put into a machine which detects the growth of the bacteria by its metabolic rate by release of the carbon dioxide. So as the carbon dioxide is produced, there is a color change in at the base of the bottle, which is detected by a colorimeter, and then which gives us a signal saying that this blood culture bottle is showing growth of bacteria. So this immediately alerts the lab personnel, and then the process of identification of the pathogen starts. Whereas in a conventional method, there are fixed intervals at which these conventional blood culture bottles are inoculated onto routine media to identify the bacterial pathogen. So the identification of pathogens is more in terms of automated than by conventional, and there is an early detection in automated around 12 to 16 hours earlier when compared to a conventional, although the conventional system is cost effective. So when it comes to the treatment of the patient, automated blood culture would be more preferable, especially in ICU settings. So coming to the epidemiology of the patients for whom blood culture samples are usually collected for the identification of the cause of the infection. So usually age, it is elderly or hospitalized patients. Children, most common. Children are also blood culture samples are also collected from the children with history of fever. Usually it is male predominance is seen, and the other comorbid factors and focus of infection and immune status are also one of the risk factors for septicemia. So the source of infection. So here, as I said before, there are two terms, bacteremia and septicemia. So bacteremia is circulation of the bacteria in the blood, whereas septicemia is when the systemic immune response is initiated for the presence of bacteria in the blood. Usually, bacteremia can also be transient. Bacteremia can be seen whenever there is a dental procedure or when there are rigorous brushings or some minor surgical procedures are done. Sometimes there can be a transient bacteremia without no clinical symptoms seen for septicemia. Usually, the order put in the slide is from the most common to the least. Genitourinary tract is the most common cause of septicemia, followed by respiratory tract, gastrointestinal tract, skin, bone and joints, surgical wounds, and intravascular catheters. So the most common pathogen seen in healthy patients with no risk factors in the community is usually Salmonella typhi, followed by Streptococcus pneumoniae and other Streptococcus species, which are most commonly seen in children, and Brucella. Common pathogens with focus of infection or with comorbid conditions are usually in hospital settings with prolonged stay, or in ICU setting are Escherichia, Klebsiella, Enterobacter, Staphylococcus aureus, and Enterococcus. Apart from this, we also have Pseudomonas, Acinetobacter, Burkholderia, Stenotrophomonas, Coagulous negative Staphylococcus, and Candida, especially when they have device associated in a device associated condition. Apart from this, we have common contaminants can be seen whenever the sample collection is not proper without proper asepsis. That is, coagulous negative staphylococcus, micrococcus, bacillus, and corynebacterium may be isolated from blood culture samples when the sample collection is not done aseptically. So these are the clinical symptoms and signs in a septicemic patient with fever, chills, rigors, vomiting, and with a clear focus of infection in some cases. Normotensive usually, but hypertension is seen in gram-positive bacteremia and when there is polymicrobial bacteremia. WBC count when it is less than 4,000 or more than 20,000 is usually truly significant for bacteremia and fungemia. So coming to the antibiotic therapy, usually empirical therapy has to be started. So before the start of the antibiotic therapy, collection of the blood culture sample is very, very important. And then after this pathogen is identified, the culture guided change of the antibiotic is also important to curtail the spread of antibiotic resistance in the community. So usually good outcome is seen in healthy patients with without any comorbidities. 10 to 15% mortality is seen in hospitalized patients 70 years above with comorbid and with other comorbid conditions. Highest mortality is associated with fungemia in gram-negative septicemia and in polymicrobial septicemia, and also with other risk factors in device-associated conditions, etc. So recommended empirical antibiotic therapy as per ICMR guidelines 2022 for salmonella infections, it is cefixime, cotrimoxazole or azithromycin or ceftriaxone 10 to 14 days. In gram-negative septicemia, it is ceftriaxone, piperacillin, tazobactam, ceftazine, sulbactam, imipenem or meropenem with or without amikacin for 7 to 10 days. And in gram-positive septicemia, it is vancomycin or ticoplanin for 7 to 10 days. And these are only empirical antibiotic therapy. The therapy has to be adjusted as per the culture and organism isolated and the sensitivity report. So the take home message is the initiate antibiotics only after the culture sample is collected. Strict aseptic process for sample collection is very important to avoid contamination of the blood culture bottle. Then automated is most preferred, and blood culture set with one aerobic and one anaerobic is preferred because it enhances the pathogen isolation. Provisional diagnosis and initial antibiotic therapy and devices associated with the patient give a clue to the microbiologist so that what type of condition and what type of pathogens can be expected from the sample and what antibiotics have to be put up for any sensitivity report. Empirical antibiotic therapy followed by culture guided antibiotic therapy should be done. Earlier culture positivity, gram negative septicemia, fungemia, old age risk factors, prolonged hospital stay, and hospital devices show a serious outcome for any patients with septicemia. Uh, so this ends the topic, and I thank everyone who is online for this webinar. If any questions are there,
Any questions from the audience? The session is open for any questions. Okay, since there are no questions, I thank Dr. Vishala Madam for her elaborate and good explanation, clear explanation about the blood cultures and their importance. And I thank you all the audience who have given their time to listen to the topic, and I hope they all follow these guidelines and treat the patients well. Thank you, one and all.